Hello, everybody, and welcome to this sixth webinar in the WGO series on climate change in gastroenterology, hepatology, endoscopy, and all the important aspects of our work. It's a real privilege to be speaking to you today, and we have a very important topic on green endoscopy. We have my name is Veitch. I'm head of the green endoscopy section of the climate change committee within the World Gastroenterology Organization. I'm speaking to you today from the UK, where I'm a gastroenterologist, and I'm also president of the British Society of Gastroenterology. I have two co-moderators today. It's a great pleasure to have Sandie Thomson from Cape Town in South Africa. Sandie has a huge amount of experience in teaching and training in endoscopy and work across Africa and elsewhere in the globe. We also have Sedat Boyacioglu from Turkey, again, former president of the Turkish Society of Gastroenterology, director of the WGO Training Center in Ankara, and has done great work with us, with the WGO and on the Climate Change Committee. We have two fantastic speakers today, very knowledgeable, very authoritative. We're going to tell you more about these important topics. Huge pleasure to introduce Lars Aabakken. Lars is professor of gastroenterology in Oslo in Norway. He has a huge reputation in research and training and practice in endoscopy and world leadership roles, including being as president-elect of the World Endoscopy Organization. So welcome to Lars. We also have João Neves. João is from Algarve in Portugal. He's been publishing important research on life cycle analysis, and carbon footprinting in green endoscopy. It's really critical we get this research. He's working with the ESGE, European Society Green Endoscopy Group, and he's really an emerging star in this area. So I'm very pleased to welcome my co-moderators on this and the panelists. And with no further ado, I'd like to move on to the first talk. So Lars.
Thank you, Andrew, and thank you for the organizers to invite me to share these ideas about green endoscopy, particularly on the aspects of single-use versus reusable equipment and instruments. I usually present this slide, and usually it has no significance whatsoever, but this particular time I think it's reasonable to mention that I am in the advisory board of AMBU, producing single-use endoscopy, and but also with the Olympus group as well, mostly producing reusable ones. So I have some conflicts, but hopefully they are more or less balanced. If you look at green endoscopy in context, obviously there is a major global carbon footprint overall, and if you look at the healthcare component of that, it's estimated between 5 and maybe 7-8% of the total carbon footprint in the planet. And within that, GI endoscopy obviously is a portion of that, but at least in the context of hospitals, it seems like GI endoscopy is like number 2 or 3 in the most significant contributors to that footprint, which also already gives us some kind of significance. This is from a publication by ESGE, just to remind you that the environmental impact encompasses a huge number of different factors, all of which can be addressed one way or another. And my topic being on single-use versus reusable, the areas particularly focused on that would be these. So the endoscopes, the waste, and the handling of endoscopy accessories. So I will elaborate a little bit on those areas, but just reminding you, and I'm sure the next talk will focus more on those, there are a lot of other areas where we can really make a change. So the case for single-use equipment is a number of things, including these. So the quality is assured every time, performance is predictable, and there is no need for reprocessing with all the components that encompasses. There are obviously commercial drivers wanting us to use single-use stuff, and maybe most importantly, no cross-contamination. We don't risk passing one bug to the next patient. there has been a huge drive for single-use accessories, including within the societies. And this is from the guidelines of 2018, where ESG very strongly said that we strongly recommend the employment of single-use endoscopic accessories. And moreover, single-use devices should be discarded directly after the use. So this is 5 years ago. And I have seen this drive over the years, where the combination of healthcare personnel working on this field, microbiologists without any view to the clinical side of things, and the industry, all of these powers together have been driving the development of single-use only business. But on the other hand, when you work in a lab, this is a picture I received from Todd Barron in the States, showing what ends up being the result of a moderate complex ERCP procedure. And in my department, this is almost an everyday output of packing material coming from the accessories that we use. So obviously there is a problem, and this is another picture from one of the papers Dr. Leddin produced, showing that we're supposed to be sorting our waste, but really we're not. And this is, you know, the product of one endoscopy lab with no sorting whatsoever. So I think we are moving in a different direction now, where the utilities of single-use equipment with no reprocessing issues, a predictable functionality, and no cross-contamination has to be weighed against another patient, the globe. And so from being completely absorbed with the needs of the individual patient only, and in every way possible protecting that person about even theoretical risks of contamination, we now have to balance that with the problems caused with our globe. So thinking about the costs of single use for the planet, I think the waste part of it is the most in-your-face component. I think looking at the pictures you just saw, it's very obvious that is not good. But I just want to remind you that in reality, the real cost for the globe of these items is not so much waste, but much more raw materials, production, and transportation of these materials, meaning that at the time when we have the equipment in our lab, most of the carbon footprint has already been established. Single-use devices encompass a number of things. I'll come back to the endoscopes part, but we have the accessories, which is the most obvious part, I think, but there are a lot of additional plastic components as well, listed here in another recent review article. And then there is all the other miscellaneous waste, including personal protection equipment, which was particularly prevalent during the COVID-19 period. But I think a lot of that has sort of been passed on to the aftermath as well. So all of this is single-use devices in our activities. Things are, however, changing. And this is a recent position statement, again from ESG, combined with ISGINA, this, the Nurse Society parallel, where now they're saying future guidelines should consider the environmental impact of these practices of reprocessing and disinfection. This was never mentioned before. And moreover, there is a need to reassess the use of single-use devices. So this is obviously just a position statement, but it shows the general tendency of the winds to swing. And even if we continue to use single-use accessories, there are ways to improve the carbon footprint of that use. So for example, we might select some specific items for reprocessing. And for me, the most glaring example would be these bougies, which to me seems extremely easy to reprocess, but still at the moment, at least in Norway, we're not allowed to reprocess it. We have to use one and then dispose of the whole set, which to me feels like completely terrible. And also there are, reusable components of some of the things we're using. So for example, handles, reloadable clips as opposed to single-use units, and some of our dilation activity also includes components which can be reused. Discretion in use, so not unpacking things you might not really need. Reuse like a biopsy forceps for uppers and colons. I know in some countries that's not really allowed with no, to me, logical explanation. If you have a patient with repeated bleeding, maybe you can keep your hemostatic spray for another go. And then I think maybe the most important thing we can do as a profession and a society would be to team up with industry for improvements as well, which for sure includes improved packaging. I know there are a number of reasons why the packaging is the way it is, but looking back at the pictures I just showed you, I'm sure there is so many ways we can improve on that. For example, a 50-page user manual of a plastic stent for ERCP doesn't make sense. That might be just a QR code on the packaging, for example. So I'm sure there's things that we can do that, and we can improve for sure our waste handling routines. This is from a British publication indicating that the more we can facilitate the functional sorting of our waste, the better we can utilize recycling mechanisms, limit the amount which needs to be dealt with as a clinical waste, and in these ways, minimize the landfill component and the expensive disposal mechanisms of our waste. And I also would like to talk a little bit about reusable accessories, because that's almost as unheard of as diagnostic ERCP these days. But I believe personally that I think cross-contamination is probably an overstated concern without any counter voices. But on the other hand, you need to consider the practicality of reprocessing these tools as well. And if you just do it for 1 or 2 or 3 items, that might not be sustainable. And also, obviously, there is a deterioration of function, which we also need to consider. So we need to consider this, but there are some other concerns to be addressed as well. Obviously, we know that in some regions of the world, single-use accessories are being reused anyway. They can be cleansed and disinfected. But again, there is an issue of functionality, and certainly there are legal implications, certainly for the companies, but even for the clinicians. And then I would like to talk a little bit about single-use endoscopes, because this has been a major driver in this whole discussion. So a couple of years ago, there has been a number of publications about outbreaks of resistant bacteria caused by cross-contamination related to hard to disinfect duodenoscopes. And particularly so in the States, where this also had major legal implications, particularly for Olympus with their 180 series duodenoscopes with a fixed distal tip cap. And so based on this, in record time, there was a development and authorization of the use of single-use duodenoscopes. First, the Exalt scope from Boston, and then more recently, the counterpart from Ambu, a Danish company who produces 1 million endoscopies, single-use endoscopes per year, but mostly in other areas than GI. And so this was cleared by FDA, and quickly there were some publications indicating that the utility of these scopes were perfectly fine, even if they're made in plastic, even if they cost a fraction of a reusable scopes, the performance was quite good. And we had the opportunity to try it ourselves, and I agree. The performance is not as good as a normal scope, but it's certainly usable. This is from a review published by some very distinguished colleagues, discussing the position of this single-use duodenoscope, mentioning again that the functionality is fine, and the cost issue has been resolved by the Medicare accepting these specific costs, which to me is a very debatable statement. So yeah, it is covered by Medicare, but it doesn't mean that the overall cost is not skyrocketing. And they suggested maybe it should be selectively used in special risk patients, but which is a reasonable statement. But if they said that immunocompromised patients might be one such group, and at least in my activity, that would encompass at least 40% of the ERCP procedures we're doing. Anyway, I think maybe the most significant part of this publication was that it was not one single mention of the climate aspect of these duodenoscopes, because there is one. This is one very interesting study showing a simulated, but still a comparison between single-use and reusable duodenoscopes, where they looked at the environmental effects on one side, particularly on the single-use duodenoscopes, and then the overall effect of the reusable ones, including the risk of the serious infections which sparked this whole process. And so I think the most important part of this graph is to show that the main climate impact of these scopes isn't really the cleaning and disinfection or even electricity, which is very similar to the other scopes, but the manufacturing, mostly the manufacturing, to some extent the transportation, but manufacturing. So they tried to look at sort of the overall effect and overall comparison. So for resource consumption, for ecosystem impact, for sure the single-use scopes were a lot worse. If they looked at the total human health impact, including the cost of complicated serious infections, they were more or less similar, but they argued that a lot of that infection component might be mitigated by better disinfection routines. There are some unresolved issues, I think, which we need to look at, because a lot of the infection risk for sure can be avoidable by better tip design and by appropriate reprocessing. It's also an enigma to me why, if the elevator is the issue, why EUS instruments are not equally affected. This is all about the ERCP, but this should really affect the EUS as well. There are a lot of things which we have not solved, particularly the biofilm, even in the non-accessible channels. And I think that if you just go looking for bugs, that might, lead you in the wrong direction, because culturing a bug doesn't really mean that that constitutes a risk of cross-infection. And then finally, I said that the duodenoscopes are usable, but they're not as good. And if you have like 5% more serious pancreatitis from your less than perfect ERCPs, you might very quickly mitigate your reduced risk of cross-infection. On the other side, to finish off, the single-use endoscopes have initiated a discussion of the general single-use equipment, not just scopes, and the real cost of reusables and their reprocessing, and the hidden costs and the carbon footprint of that illustrated by this photo of all the components going into that processing has been highlighted. And I think the vendors producing these scopes are hugely aware of the need to focus on this and to work in the direction of improved sustainability. Just to remind you, this is part of the components that goes into appropriate processing with the effort and the cost and the number of disposable stuffs which goes into that process, which has so far really not been focused. So to conclude, the overall carbon footprint of GI endoscopy is substantial, so there's something that we can do. But finally, the drive towards single-use everything has been questioned. I think that's a very good thing. Appropriate use can contribute, and appropriate waste handling will contribute. The cost and footprint of the recycling of the reusable scopes has for sure been underestimated, and the focus on that is a healthy development. Single-use endoscopes are usable, prices will come down. The added waste is moderate. I think it comes down to modifying the production process to reduce the footprint of that. But for sure, the single-use endoscopes have sparked a badly needed discussion beyond single-use endoscopes by themselves. So with that, I thank you for your attention.
Thank you very much, Lars. A fantastic talk, really informative, evidence-based, balanced, and raising some really important issues for us all, and an important debate. So for the audience, we are going to have questions at the end of this, so please do put questions in the chat. It's really important that we have a good, robust debate about these really important topics which affect us all. So thanks very much, Lars. We're now getting ready to move on to our next talk. So I'm very pleased to introduce João Neves, and we'll move forward to his discussion. But I say, please put questions in the chat, and remember, all of these webinars will be able to watch later. So if any of your colleagues have missed them, you can recommend them to them, show them to your nurses, show them to your team. But let's move on, and we'll carry on with the discussions at the end. Thank you. João.
Hello. My name is João Neves, and I am a gastroenterology resident at the Algarve University Hospital Center in Portimão, Portugal, and I'm also a member of the ESGE Green Endoscopy Working Group. First of all, I would like to thank WGO for the opportunity to be part of this climate course for global gastroenterology. Today, as part of this Greening Endoscopy and Reducing Waste webinar, I'm going to give you some practical steps to reduce endoscopy-related waste and emissions. It is well established that healthcare is responsible for up to 5% of the global carbon footprint and would be the 5th largest emitter worldwide if it was ranked as a country. However, it is important to be aware of the different dimensions or scopes of healthcare's carbon footprint. Contrary to what many may think, direct and indirect emissions from healthcare facilities contribute far less compared to healthcare's supply chain. In particular, endoscopy is considered the second highest waste generator per clinical procedure and the third highest regulated medical waste generator in a hospital. This can be easily understood by the fact that endoscopy is a resource-intensive activity that requires various single-use plastic-predominant consumables. However, the environmental impact of GI endoscopy is yet to be adequately assessed, as we currently still face a lack of interest from most stakeholders. And this obviously reflects in the absence of exact information of the material composition of most GI endoscopic instruments. The fact that endoscopy is a highly ranked contributor to climate change has alerted several endoscopic societies to the urgent need of raising awareness towards a more sustainable practice. But where should we actually start? I personally believe that these two figures from the ESGE and BSGE position statements perfectly summarize one of the main aspects of sustainability in endoscopy, which is, do not let yourselves focus solely on endoscopy rooms, because sustainable endoscopy begins but also ends outside of the room. And in order to implement some practical steps to reduce endoscopy-related waste and emissions, one must follow a circular economy model, where materials are kept after a product reaches the end of its life. By using the 5R principles of sustainability, we are able to extend the life cycle of our endoscopy products. Also, it is extremely important to be self-conscious of the barriers at the beginning of this journey and start off with small steps and achievable goals. And in an era where endoscopy is thriving and we have a growing number of available techniques, we should begin by maximizing appropriateness, where our main focus should be on doing less yet doing better. This is probably the most effective action to mitigate the greenhouse gas emissions of GI endoscopy. We know as a fact that up to 56% of upper GI referrals and up to 52% of colonoscopies are deemed inappropriate. But we have ways to lessen this burden, such as the enhancement of department vetting procedures by allowing a dedicated time for triage, the implementation of periodic updates for adequate endoscopy performance, the establishment of regular educational activities to endoscopy practitioners, and lastly, but most importantly, the pursuit of guideline support recommendation pathways and non-endoscopic diagnostic alternatives. And focusing on this last practical tip, the Baveno 7 consensus already establishes that patients without clinically significant portal hypertension do not require endoscopic assessment of varices, and there are other clinical conditions such as gastric ulcers or celiac disease that may also not require further endoscopic surveillance. We should also try to prioritize as much as possible the use of non-endoscopic diagnostic alternatives, such as the fecal calprotectin, which can be used for patients with a low likelihood of having IBD, and we also have other strategies, although some of them not fully validated, which include the FIT, the capsule endoscopy and CT colonography for bowel cancer screening, and the cytosponge for risk stratification of Barrett's esophagus. Regarding colorectal cancer screening strategies and only considering traveling and waste-related burden, the FIT test has revealed itself a sustainable alternative. The American group, led by Heiko Pohl, explored 3 different colorectal cancer screening programs over a 10-year timeframe and concluded that the FIT test may lead to a reduction of the carbon footprint related to traveling and waste of 60 to 70% compared to primary colonoscopy. However, we must also be aware that manufacturers do not disclose the ecological footprint of less invasive tests, and we still lack comparative life cycle assessment studies between these alternative tests and GI endoscopy. Recently, the French group led by Mathieu Pioche assessed the environmental impact of 3 major capsule endoscopy manufacturers. They have concluded that only 3.3% of the capsule itself is composed of useful mass, and overall carbon footprint was calculated at 1 kilogram of CO2 equivalents. They also highlighted that if we consider the need of capsule recovery devices, this will duplicate the overall environmental impact. Also, the film weight can add up to 10 kilograms of CO2 equivalents to the overall carbon footprint of capsule endoscopy. Structural remodeling of endoscopy units with establishment of energy reduction strategies also plays a major role in reducing the environmental impact of endoscopy. The replacement of inefficient bulbs with LEDs and motion sensors will grant us a reduction of about 60% in greenhouse gas emissions and lighting costs. Also, we should try to establish power-down initiatives for all inactive electronic devices, prioritizing the use of renewable energies and reducing as much as possible heating, ventilation, air conditioning when rooms are not in use. Part of this structural remodeling must also include reduction of unnecessary paper documents, such as information leaflets, printed informed consents, and endoscopy reports. These may be replaced with interactive test message-based systems for appointment scheduling and implementation of QR codes. Although more than 2/3 of patients are already familiarized with these new technologies, we have to be aware of digital divide, and whenever needed, save some double-sided printed copies on recycled paper for patients who require paper format. Rational use of accessories and adequate technique selection will allow us to reduce inadvertent use of materials. We can reduce the use of endoscopic accessories by, for example, combining both upper and lower GI endoscopies whenever appropriate, as this will allow us to reduce personal protective equipment and single-use consumables disposal, reduce water and energy consumption, and will ultimately give us the possibility of reusing accessories between procedures. We must also be able to carefully assess and anticipate what will be required for each procedure. Whenever possible, less resource-intensive techniques should be favored, provided efficacy and safety are still maintained. This should be balanced with the getting it right first time principle that aims to reduce unnecessarily repeated therapeutic procedures because a definitive outcome is not attained with the first intervention. Also, due to the risk of cross-contamination and patient safety concerns, we have been facing a steep upsurge of endoscopic single-use accessories in the last 2 decades. Indirect data suggests that the reduction in infection risk is not clinically relevant, yet carries a greater economic and environmental cost. Therefore, we must aim to prevent excess and inadvertent use of accessories by training endoscopists and the remaining staff on proper pre-procedure planning. Also, we need to clarify the definition of single-use devices, as this label is mostly established based on the decision of manufacturers. We must also be aware of the clear indications to perform biopsies, as processing these biopsies entails an added energy requirement, generates hazardous waste, and is responsible for a significant carbon footprint. A very interesting study on the life cycle assessment of gastrointestinal biopsies concluded that processing one biopsy jar with one specimen emits 0.29 kilograms of CO2 equivalents, which corresponds to 1.13 kilometers driven on an average passenger vehicle. Also, it is established that biopsies are performed in 83% of procedures, whereas clinical management is only influenced by endoscopy in about 1/6 of cases. We have strategies to lessen this burden. This should start by avoiding unnecessary routine confirmatory biopsies. We can also adopt diagnose and leave and resect and discard strategies for diminutive polyps. However, these are difficult to implement, especially due to the fear of missing high-grade dysplastic lesions. Also, we cannot rule out the important contribution of artificial intelligence as a complementary tool to help us overcome some of these hurdles in the near future. Another impactful measure is to increase environmentally preferable purchasing. This is buying a product that has been created and supplied with minimal environmental impact when compared with competing products that serve the exact same purpose. This includes consumables that are made from recycled materials, sustainably sourced and/or recyclable at end of use. Current European Union regulations do not force companies to publicly detail the composition and sources of their materials. Encouraging companies to declare the environmental impact of their GI endoscopic products is key to estimate the environmental impact of GI endoscopes and devices, and we need to challenge them to manufacture more environmentally friendly devices. This very interesting study from Lopez Munoz revealed that there are differences in composition between manufacturers. The carbon footprint of endoscopic devices with higher percentage high global warming potential seems to originate mostly from incineration, whereas the carbon footprint of devices with higher percentage of low global warming potential mainly derives from their production. These authors also developed the green mark, a theoretical recyclable mark on endoscopic devices that allowed the possibility to split the non-contaminated part of the instrument and recycle it. In their study, this avoided the incineration of 60% of endoscopy instruments' weight, leading to a 34.3% reduction of greenhouse gas emissions, emerging as a promising solution to reduce the burden associated to single-use endoscopic devices. Personal protective equipment use has largely increased within endoscopy units, mainly due to the pandemic, representing 8 to 35% of overall endoscopic waste. Alternatives, such as reusable gowns, allow us to reduce the waste carbon footprint by 66%. It is also possible to recycle some of these gowns, either by turning them into fuel via pyrolysis or by turning them into blocks of plastic. Even though waste represents but a minor proportion of the endoscopy carbon footprint, strategies to reduce, reuse, and recycle endoscopic waste are considered easy wins due to their easiness of implementation. However, most endoscopy staff is still unaware of how to adequately categorize or dispose of waste. It is thought that by training endoscopists and the remaining staff on proper waste management to achieve a target regulated medical waste percentage is the measure which will have the most significant impact on waste reduction. However, it is also true that most endoscopy suits are still not equipped with recycling bins, and just by placing these in all endoscopy units, we would be able to reduce as much as 2,700 tons of endoscopic plastic waste. In order to measure the impact of adequate waste segregation, our group conducted an interventional study on endoscopy waste management, where we assessed and compared the waste carbon footprints and waste processing expenses generated by endoscopic procedures before and after reorganizing our endoscopy unit to reduce and recycle endoscopic waste. After an initial audit, we conducted an intervention which consisted of the presentation of retrieved data with seminars regarding waste handling, segregation, and disposal in the endoscopy unit. Additionally, we acquired and placed recycling bins within endoscopy rooms and relocated pre-existing landfilled and regulated medical waste bins as depicted in the picture on the right. Our study permitted to conclude that whenever performed correctly, adequate waste handling and segregation may have a significant impact on the waste carbon footprint and waste processing expenses generated by endoscopy, and all of this can be achieved without interfering with overall endoscopic productivity or daily work routine. However, raising awareness of the staff is key to ensure adequate waste management and disposal. Each unit should elect a green endoscopy leader and some champions, and these need to be motivated and resilient people who should be responsible for staff training and for leading interventions and for reviewing existing practices in order to identify potential areas of improvement. Endoscope reprocessing is also a rather challenging topic that needs to be fully understood in order to avoid inaccurate decisions. The use of single-use endoscopes has recently increased as a result of lower purchasing costs, no need of reprocessing, and the theoretical absence of cross-contamination risks. These have been used as arguments by the industry to expand the use of these single-use scopes. Although we know that endoscope reprocessing is a resource-heavy procedure, it has been demonstrated that single-use endoscopes increase the net waste mass per endoscopic procedure by 25% and generate 4 times more waste to accomplish the same number of procedures compared to reusable endoscopes. We have some strategies we can use to reduce the impact of endoscope decontamination, and these include the installation of double basin wash machines with both booths running simultaneously, as this will lead to a 25% decrease in energy use. The use of sterile water during endoscopy is also a rather controversial issue. The rationale for its use is that the concentration of pathogenic microorganisms in tap water may exceed the infectious dose and thus cause disease. However, there is no direct data showing that the potable tap water increases the risk of infection for patients. Compulsory use of sterile water needs for sure to be revisited, and future guidelines must weigh clinically relevant infection risks, costs, and environmental concerns. However, in the meantime, there are some strategies we can use to reduce the carbon footprint associated with single-use plastic bottles, such as the reuse of procedures leftover sterile water for bedside cleaning, the use of tap water for manual flushes through the working channel, and also use final rinse water as an alternative for automated flushing systems. Telemedicine can also help us to reduce endoscopy-related emissions, especially by reducing post-endoscopy face-to-face appointments, as it will allow us to reduce waiting times and reduce greenhouse gas emissions, particularly related to traveling. However, it is important to point out that this is context-dependent, and that a careful selection of patients is paramount to avoid health inequalities. Also, incorporating sustainability into education and training of young GI endoscopists may lead to a better resource optimization. Establishment of environmentally friendly training activities, encouraging the correct use and disposal of GI endoscopic devices, as well as an overall attention towards environmental issues, may help to shape the ethical mindset of future generations of endoscopists. Also, endoscopy simulators and on-site, off-site teaching modules are essential to reduce unnecessary waste during training, allowing the reduction of the learning curve, whilst guaranteeing the development of a set of skills to perform safe and efficient procedures. Lastly, it is important to involve our patients, allowing them to have control over decisions and actions affecting their health, as well as promoting healthy lifestyles to avoid overuse and overtreatment. To conclude, although it is crucial to consider GI endoscopy's environmental and social impact, we must not forget that our patients' clinical outcomes are our priority. Most immediate actions must include reduction of the rate of unnecessary procedures, as we should always think if the endoscopic procedure we are about to perform is in fact truly necessary. And we also need to implement circular economy principles into GI endoscopy practice. The path towards sustainable endoscopy may seem rather complex and discouraging, but remember, if you do not know where to begin, establish a list of priorities. Start off low, build a good and solid foundation, and endure. As he that can have patience can have what he will. Thank you very much for your attention.
Thank you very much. Fantastic talk. I mean, really practical, really comprehensive across the whole patient journey, training, all aspects of endoscopy, and with some real world experience from yourself there. I'd like to invite all our speakers and moderators up. Just to kick off, what I'd like to ask you, João, you've demonstrated fantastic work in your own unit. We'd all like to do this. Everyone's busy. How do you go about it? How do you persuade people? How did you actually make it happen? And what were some of the barriers you came across? Because I think there's a lot of enthusiasm to do this, but how do we actually make it happen when we go back to base and in our own units?
Hi, first of all, thank you very much. So basically, the main aspect, and I would like to stress that, is that you always need a green endoscopy champion. Otherwise, if you don't have a leader within your endoscopy unit, you won't be able to establish this type of measures. And then I would suggest to leave some of the team out of the project, just to be sure that you do this under the radar, and then just present the results to them, because they get completely overwhelmed when you present the data. And when you try to implement some of the measures, they are really keen on putting them into practice, because they know the reality of what they've been doing. And I personally also think that it is easier when you have a smaller unit, because you have a more close contact with each other. And I can tell you for sure that at the moment in my unit, they're still practicing this without any need of reassurance. So I think if you start off with these small steps and you try to implement in their unit, talk with your team, tell them what you're doing correctly and what you're doing wrong, they get the notion of what is the path that they need to follow. And once they know this, it's automatic.
No, that's fantastic. And I think the important, as you say, of having green champions within your unit, it doesn't necessarily have to be a doctor. As I was saying in the introduction, I think the senior nurses particularly that often run our units and run our lives in endoscopy. And I think it's really important. Lars, you pointed out, of course, that a huge amount of the carbon footprint, and we've seen this in other studies, is in the supply chain, in the transportation, the packaging, everything. It's not just what we can do in the unit, but presumably, if we all do a small amount, that adds up. But can you give perhaps some reflections from what's happening perhaps at home in Norway or elsewhere, other experience you have of how we're managing to make some transformative change in this area?
Well, I think the fact that we're having this webinar is one of those steps. We did this survey in the context of WGO, reaching out to the various national societies in GI. And I think the prevalent response from the presidents of those societies, and specifically from the president of the Norwegian one, was, we are aware, we would like to do something, but we're not quite sure what. And I think that sort of trickles down into a lot of the endoscopy activities, and certainly into mine as well. So I was very, very happy to hear João's talk, pointing out really hands-on practical steps that we can take, because, doing those small things, even though, like I said, the main footprint may be happening elsewhere, starting at something which is tangible and observable, I think is hugely motivational. And I think we need that motivation from sort of the grassroots level to instigate the other changes as well.
No, I think those are really good points, because I say that the green endoscopy issue, the waste, the pictures you showed, we see this, every day on our list. It's something that people can make a real difference with, and I think can get our colleagues across all disciplines in our service engaged with, because they can see the differences straight away. I think politically we can, as professional societies, we can do a bit. In the UK, we're very privileged that the government has actually enshrined in law steps to reduce the carbon footprint in endoscopy as part of its greener NHS program. It's actually tackling the supply chains. And it's actually the companies will not be able to get procurements within our public health service unless they're showing green credentials. And I think we're probably unique in the world in that, and it probably reflects our health service as well. But I think that's perhaps an example for others throughout the world in tackling this, or funders. It doesn't have to be governments. Yeah, Lars. Yeah.
Well, just one little point, because I think we all complain a lot about the packaging and all the instruction manuals and all the things put in our baskets by the industry. But I do believe that a lot of that is not really instigated by the industry. It's instigated by all sorts of regulations by our authorities. So even though we can address the industry, I think at the end we also need to team up with the authorities to look at the regulations which the industry has to relate to, which may a lot of it be completely useless.
Well, and let's hope that global organizations like WGO, like WEO, and the North American societies, the other big and South American other societies that are coming together, if we get some consensus, then we can perhaps influence that regulation. Sandie, I'd like to ask you a question, but I've very small but very enjoyable and rewarding experience of working in sub-Saharan Africa. It strikes me that's probably the greenest place you can possibly work, because you reuse everything. So what's your kind of reflection on this, and how we can, and you probably don't do too much inappropriate endoscopy either, but what's your reflection on this?
Well, I think endoscopy is a scarce resource in Africa. And I think all this, much of what João said about sort of not doing unnecessary endoscopy applies even more in our setting. But the healthcare sort of, shall we say, the referral patterns are the things that to get the patients who need endoscopy to the endoscopists, and not to do unnecessary endoscopy. But I have a few questions. I mean, we're not the only society doing endoscopy, and the urologists, the anaesthetists, and the ENT surgeons have been using disposable scopes for quite a long time. In fact, I think most of the thrust until the duodenal problems with cross-infection were sort of driven by convenience in these disciplines. So my question, Andy touched on it, but for the others, how do you get champions in the other disciplines? Are we really the big bad wolf? And how do you approach it in the context of your whole hospital going this way? Do you have champions in your hospital apart from the GI docs or nurses?
I'll answer quickly for the UK in that there is a national program on this, but I'd like to hear others. And Lars, with your association, your knowledge about the disposable endoscope industry, obviously, it has been used in other flexible endoscope disciplines as well, particularly urology and just the disposable bronchoscopes, things like that. Are there other sort of green movements coming out in other disciplines as well?
I would be very surprised if there isn't, but I'm not completely sure personally about that. But what I do know is that because of this green, the climate push, I do know that the companies are eagerly looking at this. And I mentioned the imprint of production, which also goes into the raw materials. And I do know for a fact that there is a huge push, for example, away from oil-based plastic production to bioplastics and other sort of productional changes, which might, down the line have a much more significant contribution to the overall imprint than the waste segregation and other things that we can do. So I do know that the companies are focusing on this, obviously because they have to, but I think that is still a significant thing, and I'm sure that relates to the other specialties as much as for a GI per se.
I think there's certainly a lot we can learn from other specialties. I know that anaesthetists and theatre environments are doing a lot as well. Particularly anaesthetists been driven by anaesthetic gases. But I think that, I suppose my comment about this is these scopes came out. There's a lot of marketing that goes with them, and but you know, they're getting pushback and they're getting challenged from the community, and that's provoking a great debate, which is driving us to look at lots of aspects of our care, including the conventional one. I'd like to give Sedat an opportunity to comment. Really, I'd like to know what's going on in your part of the world and any questions you have.
Well, the first comment I'm going to say is about the socio-economic status of the countries, which you already have mentioned about sub-Saharan countries. In our region, in Middle East and Southeastern Europe, I think most of the hospitals, the endoscopy units, are using reused accessories for endoscopies rather than disposable, rather than single-use one. And even I know in some hospitals they use, even in mine, we use disposable ones more than sometimes 10 times. So I think this is better for the environment than the companies economically. My question is about how about the carbon dioxide insufflators that we have started using very commonly, especially during ERCPs and colonoscopies, because of the less complications to the patients and more comfort to the patients. But is it good for the climate change to use instead of air insufflators? Do any of the speakers, or you have any comment on this?
Well, I'm happy to start with a comment about the CO2. I think CO2 can be particularly useful, rapidly absorbed, and particularly in the patients who are sedated rather than anesthetized for endoscopy. But it has got a much bigger carbon footprint than CO2. I suppose we have to go back. Aabakken, I'd be interested to João's comment on this. Is look at the appropriate use for the right, use it in the right patients. And simple things like make sure you switch it off in between procedures. Don't let it leak. Yeah. Manage the system properly so that you're using it in an appropriate way. Yeah, do you have any comments about CO2?
Yeah, getting on that point correctly. I've got sometimes people that do not turn off the CO2 bottles in between procedures, so that tends to waste a lot more. But I fully agree with you. We need to optimize this within procedures. So if there is a patient that needs a long colonoscopy, where you're going to perform polypectomies, mucosectomies, or ESCDs that in fact take a long time, I think you should definitely use CO2. But I mean, if you're going to do a full diagnostic colonoscopy, which is rather more quick than an advanced technique, I think you can switch in between CO2 and air within the same procedure. I think you can mix both of them. But as you stress, we should maintain as much as possible the comfort of the patient, because we know that using CO2 is a much more comfortable for the patient in terms of CO2 absorption and pain after the procedure. So, and also the risk of any type of complications.
May I say something regarding the other strategy to reduce CO2, certainly in colonoscopy, is to use water immersion.
Yeah.
And we use tap water for that. We don't use sterile water for that.
Right.
And that's one way. Then you're only going to use CO2 on the way out. And you may not need to use it so much on the way out. So it is another strategy.
And I think also the for upper endoscopies, there is no evidence of any utility of CO2 at all. I think that's came along with the other procedures, where it has been shown beneficial.
Yes.
There are some questions from the audience.
Yes, we have. Yeah. We just got to. I mean, I'm just looking. I've got them up on the Q&A now. So this is a good one. Yeah. So before starting endoscopy, should we make sure we're doing this in our normal home lives? So that's a challenge to us all. I think the answer is obviously yes, but I think you know, I think we, you know, as professionals and professional societies, certainly professional societies, we're trying to put our money where our mouth is and set an example. And I think we should all be thinking about this in our own lives as well. Probably bit too big a question to answer properly individually in the limited time we have available.
There is a question here from South Africa from Peter Barrow. And again, it applies to us working on the subcontinent and other areas which are low resourced. And that is, most of our endoscopes are reprocessed. Sorry, I got my lips around it. By manual reprocessing. Is that creating a bigger or a smaller footprint? Because by and large, these washing machines use lots and lots of water, and so should there be a shift back to manual reprocessing? In some ways, it's quicker, even if it's done properly, because of the sort of logistics of putting it through a reprocessing system. So what are the views on perhaps not moving to washing machines in such a big way, especially in small units?
I mean, maybe I'll ask Lars, you've got obviously experience of working in low resource environments, but also I think you made some important points about the infection risk problem, and particularly with geodescopes and elevators and things, how some of it is probably down to inadequate manual reprocessing aspects of it. And I think some of it has also been superseded by disposable caps and things. But what do you think perhaps about the manual reprocessing that goes on in low income environments?
I think that the number one important component of the reprocessing is the manual cleaning. If that's not properly done, no machine can do a good job after that. So and that part, the manual cleaning part, is manual anyway. And I think that like Sandie says, if you do the rest of the thing manually as well, the quality is at least as good. I'm sure the footprint is less. The risk is you said, Sandie, that it's quicker, but it's also an opportunity to cut corners, which I think is a potential concern. And also obviously in your region, the manpower cost is less, which obviously is a factor as well. But in many of those countries, particularly where the water quality is difficult and the machines may malfunction for that reason, then at least in that area, I tend to advocate manual cleaning, maybe with those specialized trays as a facilitator.
I'm just wondering about, one of the discussions that's come up, and actually it was something that Mark Topazian mentioned to me a long time ago, is with disposable scopes. I mean, obviously they're still relatively expensive at the moment, but the price could potentially come down. But if I could see that in Africa, a remote environment elsewhere in the world where there are limited resources, if you had a cheap disposable scope that was affordable, then that might be a use for them. You still have the waste issue, but in that limit, what do you think about that, Lars? So you get them down to a couple $100 or something? Is that, do you think
yeah, I'm sure the price will come down. I still worry that it might be too costly for the most patient in that region. But my dream had been to use these instruments or a variant of them as like oligoscopes, so that you don't use them one time, but maybe 20, because the maintenance of the reusable scopes is a huge problem. And if there was a way to use these scopes several times, like every other single-use item is, I think that might be a potential way forward. But I think it's difficult for a number of reasons. But I keep dreaming about it in the night anyway.
Yes.
I mean, I think we're all. Sedat, please come in. Yeah.
Yes, there was an interesting question at the beginning of the panel. He's asking, how about using solar panels instead of power supply in the units?
May I comment on that?
Yeah, please.
There is a very interesting place in Uganda where the surgeon has set up a very fancy in the middle of rural Uganda, where Jerry Way has set up a based on solar panels. So their hospital in the middle of Uganda is powered by solar panels. It has some fairly fancy equipment. But I think that's another issue which is much more global in terms of what the hospitals do about their energy supply and how you set these things up. But I think changing to LED lighting, changing the scopes to LED lighting, these are all things which will, really reduce are practical little things that we can do, like placing the recycle bins in the rooms. That to me sounds like somewhere where we should all be going right up front, and making sure that our hospital has a policy. That's why you need other champions. I think that you should be trying to address this at the hospital level, because recycling is an issue for the whole hospital, and then take it into your own unit.
And you have to have sunny days, lots of sunny days, not in Norway, I think.
Yeah, well,
Midnight sun,
Midnight sun. But I think it's a good point. I think that a lot of people will be working in institutions, perhaps where there is a sustainability policy, there is recycling, there are things going on that we're just not connected with. And so I think make that inquiry in your own hospital. I mean, I appreciate less so in the much, lower resource environments, but certainly in those of us who are working in developed environments, those things are probably already happening, can be connected. And that's another way to get support for this with our own organizations. I think we've had fantastic discussions today. We could carry on this for another hour quite easily. But the debate goes on. There are 3 more webinars coming up. But next one in 2 weeks' time it involves nursing issues, really important personal systems, the advocate to mitigate the crisis. Any of these talks will be available, the ones you've missed, the ones coming up. You just need to register. You can watch them retrospectively. We will be looking at them, putting together as packages. I think it'd be really good if people could use them as teaching aids in their own units. Get when you have your academic or educational meetings within your endoscopy service or your GI service, is to show some selected highlights from this, educate people, make them aware. And ever since we started on this journey, we're just learning new things. The other thing I think that's really coming out, which is really important, that João and Lars are involved in, and some others, is the research side of this, because there are gaps in our knowledge. I think that we need data, not just for ammunition, for advocacy, but to learn how to do things better and to measure our success. And I think that's, again, that's really exciting work that's coming out now, and there are global collaborations going on with this. So again, I'd like to thank our speakers. I'd like to thank our co-moderators. I'd really like to thank the WGO for organizing this and for taking a lead in it. I know this is happening in lots of other organizations around the world, and it's really exciting to hear. I've just come back from DDW last week, and we had a symposium on green issues there. So it's taking foothold throughout the world. So thank you very much, everybody. Thank you very much to the audience. But please spread the word on this important issue. Thank you, and goodbye to everyone.
Thank you. Thank you.
Thank you. Thank you very much.